do have 2 more rural settings and a more urban setting. And the educational strategy that we've actually been using has been more effective in the rural setting than in the urban one, which we can talk about later. But I think that there may be some lessons that we can share with you that we have learned from that. Our educational strategy, again, looks very simple, but it actually has been crucial in helping us move along. And needs assessment has been talked about a lot, and I'll share with you how we've done our needs assessment, because our evaluation strategy has completely driven our needs assessment, so we keep cycling through it. And I'll try and share with you that, and maybe we'll have time to discuss it further. Also the low tech of slides, as opposed to your PowerPoint. If you look at education, continuing education as being on a continuum where the institution is kind of like us, the university, the center, and going to a complete community base where it's driven completely by the community. We try to look at it as the continuum. When we started this in 1994, when we got this mandate from the Ontario government to be responsible for the education of physicians and for a pain and symptom management team for this area, we were actually quite university-based. We had physicians come for 2 weeks and spend time on our unit learning palliative care stuff. The allied health care professionals got some education from the pain and symptom management team, but again, more driven by us than by them. We developed some very important partnerships, but after several years when we evaluated that program, which was published in the Journal of Palliative Care, it became clear that that model wasn't working anymore. Physicians were going back. They didn't have the supports when they went back to their communities to do what they learned to do. They weren't functioning as a team. So we changed the model, and we made it so that we did 3 different programs, one based in Ottawa, Carleton, one in the 5 eastern counties, and one in Renfrew County, where we pulled together the key stakeholders in those communities, people who were doing palliative care. A lot of them were the people who'd come to our center, so we already had a relationship with them. And we held focus groups. Now, this is where the needs assessment comes in. We had their part of the learners who'd been with us saying what they wanted to learn. We also had what we knew they should know. We were kind of like the experts. And we also now had the community saying what the community wanted to learn. And so we brought them as outline of a curriculum, and then they helped develop what they wanted for their community out of that. So all those together to build the program. They developed small working groups that came out of that. And then we built in this sort of evaluation strategy where we continued using the focus groups. They meet once a year with us, and we get new people coming together to say where it needs to go. We also built into these programs for 1998 a pre-post test, and there was obviously learner satisfaction. We went to patients and families, actually it turned to be bereaved families, asking them what they wanted their practitioners to know, and used some basic studies and looked at what impacts we were having in the community, not in a systematic way to start with. But we definitely moved it out from us. And there were certain things that were happening, what I called the serendipitous ripples, that were happening simply because of our educational program. There was no other reason for them to happen, and they reported to us. They got together and decided they needed regional rounds in one rural area, so they hold those like once a month throughout the year. Another hospital started doing palliative care rounds for their small team. We got into grants with them because they realized they wanted to become better educators, and we got a grant to do adult education workshops around the different communities. So lots of different things started to happen. And the other thing that started to happen was that the community people became much more responsible for what was running in their community. We're becoming much more facilitators rather than drivers of the curriculum. So in terms of the needs assessment, it's an ongoing thing. It's more like a spiral. It's not flat. The evaluation drives us to different changes. And we always get the learner's perceptions. I think that's part of it. But we also, as you've all been hearing, you need those other pieces to be able to build a proper curriculum. There were certain things that we did in our strategies, I suppose, that helped people feel more empowered and helped us get the projects going. the teams themselves chose the venue. The teams themselves planned, the working groups planned their timing. We helped them choose educational methods that were going to be educationally sound. And they helped drive the curriculum and the content that was going to be used as well. And then the methods, and you've all heard of these things, but they actually are very important. We use different techniques. We definitely use local experts who were experts to come in and talk so that each community got their sense of what was going on. We use things where the community resources, instead of being a panel in the front, would go to each team that was sitting there and share with the team. And then it would rotate rather than going from panel to panel. We used community theater as an educational tool where the theater group we gave them the roles to play, and then they stayed in roles so that the different teams were able to interact with them. And I forgot to tell you, one of the most important pieces was that all of our education was interdisciplinary. We had common, and we limited the numbers so the docs didn't get overwhelmed by a whole group of allied health professionals. But all the groups were together. They had certain sessions that were together. Then they would be separated out for specific things for docs for assessment and nurses for assessment and management, that sort of thing. But they would always be brought back together to work on common clinical cases so that they would work in teams. And so when I'm referring to teams, we actually made sure that there was a doc at a table with nurses at each one instead of a clump of docs and a clump of nurses. We actually coordinated their seating, so they would do that. And then things like that got into the newspaper. The local amateur group got it into the local newspaper, showing what they were doing in the educational pieces for their community. The other piece that was very important to allow us to have ongoing things with our community was, first of all, the annual community focus groups where we plan what we're doing the next year. And that's one piece that's always there. We have a 24-hour, 7-day-a-week telephone line contact for any professional in the community. So if they're getting into clinical problems at 2 o'clock in the morning, they call and they get one of us from the Palliative Care, Institute of Palliative Care, who's on call for our unit. We take their call and help them through clinical situations if they're having trouble. There's ongoing, as we say, we taught them to be better educators, and that's been an ongoing piece. We try, they get information. We have a little publication called Pal Connect that they get on a regular basis. That's issued 4 times a year. It's also available on the web for them to get to, and we're exploring new ways of doing, using the web for them as well, and the internet and emails, that sort of thing. And I think David mentioned the reflective component, and that's definitely in all of the sessions. But it changes, and what happened this year when we went back to them and said, what do we need to do? Well, they said, you know, this 30-hour program, which is what the initiative has to be, is too much. We're not going to get anybody out to do it anymore. And so what we did this time was take those people who were still motivated, and we formed interdisciplinary teams where there's a physician on the team that has to be there for the initiative, but the rest of the team can be whoever they want, and we've asked them to make sure that there's administrators, there's nurses on it, to develop an educational project for their community, for their specific community. So, and this is where it hasn't worked in Ottawa, Carleton, because the projects didn't get off the ground. Nobody took the bit in their teeth and ran with it. But in Renfrew County, we had 6 teams, and 5 eastern counties, there were 3 teams working. And they basically they've all developed educational components. We use 30 hours to teach them about project development, change theory, writing grants, using the internet, that sort of thing, to develop their own projects. And they're very exciting projects which are linking them regionally as well, but actually very specific for their own communities. And I can tell you, I'd be happy to share with you later what those are. So basically, in summary, our goal has been to try and get more community-based each time that we've gone. And it's a slow step. We couldn't have started with this community educational project for them doing it if we didn't have the partners from before. And it's just been a slow, ongoing thing where they become much more responsible for it, what's going on, and we support them. So that's what we've learned.
Thank you very much.